Hello, everyone. Good morning or good afternoon, depending on where you're calling in from. On behalf of the Centers for Medicare and Medicaid Services, the Administration on Community Living, and the Indian Health Service, I would like to welcome all of you to our monthly long-term services and supports webinar series. My name is Sarah Peterson, and I work for Kaufman & Associates. I'll be the moderator for today's webinar. As we're getting started, I'd like to highlight some features of your webinar interface. You can see the PowerPoint slide in the main window, and at the bottom right-hand corner of your screen, there's the Q&A box. Today's question and answer period will be at the end of the presentation, but you can enter a question for our presenters at any time in the Q&A box. In addition, if you need technical assistance during the webinar, please enter your tech support question in the Q&A box as well. We monitor those questions throughout the webinar and will answer your tech support questions as soon as possible. You'll receive an answer sent directly to you in that same Q&A box. In the middle of the right-hand column, you'll see a box titled Download Today's Slides. If you'd like a PDF copy of today's slides, click the file name to highlight it and click the Download Files button at the bottom of the box, and follow the dialog boxes to open or save the PDF. If you explore these files, make sure to come back to the webinar by clicking on the green Adobe Connect icon in your taskbar at the bottom of your computer screen. Finally, please be aware that today's webinar is being recorded. The recording will be made available online at cms.gov on the Long-Term Services and Supports Technical Assistance section. We'll have it up there in the near future. With those announcements made, I'd like to thank everyone for being here today. Our webinar is an overview of the Department of Veterans Affairs and the long-term care services that they offer and how to access them. I'll begin by introducing our speakers. Dr. Amy Light is the co-clinical director for the Rehabilitation and Long-Term Care Division at the Portland VA Medical Center in Portland, Oregon. She has been with VA since 2010, and prior to that, she was a member of the U.S. Public Health Service and served for 21 years with the Indian Health Service in Arizona, 15 years on the Navajo Reservation, and then 6 years as the Chief of Medicine at Phoenix Indian Medical Center. Her current career focus with VA is expanding non-institutional care for veterans through improving clinical processes and building collaborative care teams, and providing medical and psychosocial care to the most medically complicated veterans. Mr. Joe Davis grew up in Royal City, Washington, a small agricultural town in eastern Washington. He enlisted in the Army Reserves in 1989 and served in Operation Desert Shield. He reached the rank of sergeant before leaving the Army in 1993 to return to college. He remained in the Army Reserves and returned again to active duty after completing school, and he participated in Operation Iraqi Freedom. In 2005, he left the Army and returned to civilian life. He joined the Portland VA healthcare system in 2012 as the enrollment supervisor. And I want to welcome both of you, Amy and Joe, and to thank you for presenting with us today. As we begin, we're going to do some polling questions for our audience. And I'll open both of these polls and give each of you a chance to answer them. So you can actually read the questions and click the boxes that are right on your screen. And we will see your answers coming in and get to have a better sense of who you are as you're joining today. Great, thanks everyone. I can see the answers start to come in. I'm going to go ahead and broadcast the results so we can all see and get a sense of who's from where and what type of representation we have from different roles and different areas of the country. So as I'm seeing these answers coming in today, I'm looking at the rural and urban question at the bottom of the first question, and I'm seeing that although we have both groups represented, we definitely have more folks coming to us joining today from rural areas. I also see as folks are entering their roles or positions that we have really a high concentration of social workers or case managers and administrative folks. And that's great because that's kind of the role that we're focused on as Amy and Joe will be presenting today. I'm going to give just another moment for people to keep checking the poll boxes if you haven't had a chance to enter yet. And Amy and Joe, I'm going to ask you to get ready for me to turn the presentation over to you. I'll move back from these poll questions. And Amy, please go ahead.
Yeah, thank you, Sarah. And to everybody on the line out there at this webinar, thank you for joining us. It's my pleasure to speak to everybody out there in Indian country today because, as Sarah mentioned, I spent 21 years in Indian Health Service in a rural area, Tuba City. This is the picture where I spent 16 years, and I lived up on the reservation during this time, and then I was down at Phoenix Indian Medical Center. So I worked mostly with the Navajo and Hopi tribes, but at PIMC we have 300 tribes a year coming through, so I have extensive experience working with a lot of different cultural groups in cities and in the rural areas. So now I can give you a perspective of the VA, because we're a huge bureaucracy, and so I hope that we can give you, Joe and I are going to try and give you the basic information we think that you need to be more effective in interfacing with the VA. Next slide. Okay, thank you. Whoops, I'm going back, Sarah. Okay, I'm going to put in some pictures, some of my favorite pictures from Tuba City, since I remember it so fondly, and I don't get many excuses to show the pictures. So this is the Hopi village, and pictures right around Tuba City. And as you may or may not be, well, you're probably aware that the Native Americans serve in the military at a much higher per capita percentage than other races in the United States. I had the privilege to actually take care of code talkers when I was in Tuba City in the late 80s and 90s. And that's a picture there on the reservation that honors the code talkers that were alive at that time. So the objectives, again, is to give you an overview of the VA, and then most importantly, to tell you about eligibility, and that will be Joe Davis's job. And then I'm going to give an overview from a federal and national perspective of some of the long-term care services that we can offer.
Okay, as we're moving into the content section of our webinar, we have another question for the audience. And that question is, are you familiar with VA long-term care services? Have you used them for yourself or a client before? We want to get a sense of what kind of knowledge people are coming into this webinar with. As folks are starting to answer, I'm going to go ahead and broadcast the results so we can see who's making up our audience today. And I'm definitely seeing a higher percentage towards the sides of less familiar with VA and long-term care, although there are some folks who are very familiar, and there are some folks who either have used or have helped their clients use VA long-term care services. I'll leave this poll open for just another minute or so. I see a question in the Q&A box. An audience member asks, can we mark more than one? And I believe that you can. I think they're check boxes. So if more than one applies to you, go ahead and check more than one. Okay, great. So here's our kind of final overview of people's level of familiarity, and it looks like most of our audience is only a little familiar, while some people have definitely more experience. I'm going to go ahead and close that poll and bring us back to our presentation and give it back to Amy.
Okay, so looking at the spectrum of people who are out there in familiarity with the VA services, I think that, well, Joe and I tried to make this a very useful presentation for people from the outside who just need basic information about where to even get started with the VA. That can be a difficult thing. So to start with, the mission of the VA, it's a federal agency, and the mission is to care for, as Aide said, to care for him who shall have borne the battle and for his widow and his orphan. The VA was established in 1930. It's at cabinet level. In 1989, it's the federal government's second largest department after the Department of Defense. So the VA is divided into three basic administrations: VHA, the Health Administration, Veterans Benefits Administration, VBA, and National Cemetery Association Administration. So people always say VA, and by default, they sort of mean the VHA. But really, there are two other administrations within the VA. So a little bit about the three branches. Let's start with the little ones first. So the National Cemetery, 131 VA National Cemeteries and 9 tribal cemeteries. VBA has 56 regional offices, but the VHA is the behemoth of this group. It's one of the largest integrated healthcare systems in the world. There's over 150 medical centers. So Joe and I work at the Portland VA Medical Center. It's called VA Portland Healthcare System now. The name changed a couple of years ago. And there's 890 CBOCs. So Sarah warned me that we're acronym heavy. That's clinic-based outpatient clinics. So here at the Portland VA, we have 11 CBOCs, or outpatient clinics, in our network of healthcare systems. We also have community living centers, which is what we call our nursing homes, and I'll talk more about that at the end. The other programs are listed too. We have over 300,000 employees, the second largest cabinet agency with 21,000 mental health professionals. 9.1 million veterans are enrolled at the current time for VA healthcare. And again, it's VA. We just say VA, but we're assuming that you know it's Veterans Health Administration. And our mission is to provide exceptional health care for our veterans that will improve their health and well-being. So I'm going to turn it over to Joe now so he can tell you about eligibility.
Thank you, Amy. It is important that everybody understand this part of it, because to even access the services in the VA, you have to be an eligible veteran. And eligibility is one of the most misunderstood aspects of the entire VA system. The Federal Code of Regulations defines a veteran as a person who served in the active military, naval, or air services and was discharged or released under conditions other than dishonorable. So that other than dishonorable is important. A veteran who has a dishonorable discharge by law is barred from receiving federal benefits. So right off the bat, if someone has a dishonorable discharge, there's no point in even going any further at that time. So once we get past that point, we start to do determination of eligibility. We start by looking at a couple of things. The veteran has to have served active duty. This is not to be confused with active duty for training, which is what you do when you join the reserves and you go to basic training and you go to your tech school or AIT, and then you come back home and serve 1 weekend a month and 2 weeks in the summer. That short period of active duty, since it's for training only, does not count. Active duty is active duty. You sign up, you're going to do this full time. Now, prior to 1980, the requirement was 1 day. As you can see, there's a couple of dates, 1980, 81, where there's a change in the legislation, and a veteran has to serve 24 months of active duty. There are a couple of exceptions to that criteria, but generally speaking, that's one of the first things we look for is 24 months of active duty. The discharge, and as you can see, other than dishonorable, we're primarily looking for honorable discharges. There are a few in between that we turn over, as Amy was talking about the different branches, the Veterans Benefits Administration. One of their tasks is to take these bad conduct or other than honorable discharges and make a decision as to their overall value. And they may choose that overall those are dishonorable, and then that veteran is not eligible for care, or they may choose for those to be honorable, and then we move forward to look at the other eligibility criteria. There's two aspects that we look at as far as the second part of the eligibility, and that is service-connected disability or income. Sometimes we look at both as two aspects of the eligibility that influence other factors. So the first thing is we would look at, does the veteran have a disability that is rated by the Veterans Benefits Administration, and is that a compensable, meaning it's 10% or higher? You can get a service-connected disability of 0, and there's no compensation for that, and that does allow you to get a limited amount of health care. But if you're a 10% or higher, then you're going to be automatically eligible for care. If you don't have a service-connected disability, then we look at your income. And across the country, there's two income levels. There's the geographic threshold and the national threshold. So we look at it on a zip code level. And if your area is a lower cost of living area, then whichever one of those two is the lower, it would be the one that applies. Here in Portland, we're in a higher cost of living area, so the geographic threshold is significantly higher than the national threshold to allow a greater number of veterans access to care. You'd want to talk to a person at the VA to look at that, or you can do a little research. Those numbers are available online. One of the biggest things with eligibility, when someone is determined to be eligible, they're placed into one of 8 priority groups. Depending upon where they fall, priority groups 2 to 8 may have some co-payments. But predominantly you'll find if you have a veteran who is utilizing care other than the VA, and maybe some of them other than the tribal clinics, if they're looking at having co-pays, those are probably higher. So the VA is a way of bypassing some of those higher co-pays. And I don't want to go into a lot of detail here. You're going to want to ask somebody at your local VA to help you identify exactly which ones apply. And I think for today's conversation, the big one is the max of $97 a day for the long-term care. And it sounds like we've got a question.
We do. We have a couple questions that are coming in on eligibility, and I'll give it to you. And, if you find that they are too specific, feel free to tell folks where they should go next for more information on them. But I think some of them are a little more general. The first question is, when is a person who is a reserve considered on active duty to be considered eligible?
So that's a good question. A lot of times reservists are called up to serve in an operation. What's important is that if that operation falls under Title 10 and those orders are signed by the president, that is federal active service, and all it requires for that reservist is to complete the period for which they were called to active duty. And I want to make this clear, there's a distinction between when you're called up by the president versus when you're called up if you're in the National Guard, by the governor of your state. So if you're called up to fight a wildfire or assist in other natural disasters, and that's a state-level operation, that time does not count for the federal government. It has to be Title 10.
Okay, thanks for that clarification. Another question here is, can you clarify service-connected and non-service-connected?
So that simply means in the VA world, service-connected means that you have a mental or physical condition that the Veterans Benefits Administration has determined to be caused by or compounded by your time in service. And I use myself as an example. I was injured while on active duty, and I claimed one of those injuries, and that injury gives me a percentage. I'm service-connected. A veteran who has never filed a claim or was lucky enough in their short time or even a career perhaps to never be substantially injured or ill and doesn't have anything to claim, they would be non-service connected. So those terms don't relate to whether or not you were in the military. They relate to whether or not your medical condition is related to your service.
Great, thanks. Another question we have is, what is the eligibility criteria for those who served prior to 1980? For example, Vietnam veterans, et cetera.
So let me go back to that slide for just a second. You'll see that the two dates apply to whether the veteran was an enlisted member or whether they were a commissioned officer. So if they were enlisted, which of course, 70% of all veterans are enlisted members, and they served before September 7th of 1980, then if they were on orders for active duty and they went to basic training, that one day is all that matters. Beyond that, it becomes the discharge and the income and the rest of it. If they started their service on 9/8 of 80 or beyond, they must serve 24 consecutive months. And then the same applies to the 10/16/81 date for officers.
Okay. Another question is, does active duty include recruiters?
It does. In fact, my last duty assignment before I left the Army was as a recruiting company commander, and myself and all of my recruiters were all active duty. Even the reservist who was recruiting for the Army Reserves. Now, keep in mind, when it comes to the Air Force and the Army, we have a separate entity, which is the National Guard. And the National Guard belongs to the state where they are assigned. So if you live in Washington State and you serve in the Washington National Guard, although your uniform says U.S. Army, you are owned and operated, so to speak, by the governor of that state. You're not a federal troop until you're activated by the president on Title 10 orders. So all that time that you spend working for the state, thank you, but it doesn't count for federal time.
Okay, the final question we're going to take at this point in the webinar is related another eligibility issue, and the person asks, when determining eligibility, the active duty information would be listed on their DD-214, is that correct?
Yes, it is. That's the document that gives a basic summary of all their military service, and it's the most important document when it comes to determining eligibility. And a good eligibility specialist can read over that one-page form and at the end know basically everything they need to know about that person's time in service.
Okay, great. Thank you. We're going to shift back to your presentation. I want to tell the audience, if you have questions, go ahead and enter them in the Q&A box, and we'll return to them at the end of the presentation. Go ahead, Joe.
Thank you. And just to wrap up my portion here, in the 5 years I've been doing enrollment, we tend to become kind of the last resort or the first go-to people for almost everything because they're familiar with it. We tend to know a lot about everything, a little bit about everything, I should say. So we know who the right people are, and they tend to rely on us. But there's actually a lot of tasks that don't fall into the enrollment office. So, at your facility, if you're looking for some of these other services, you may ask around, but there's a lot of things that enrollment doesn't do. So we like to refer people out to those other offices, and we'll assist you if you need in directing you to where those are. But understand that's not us passing the buck. It's really about that's not something we do. Somebody else handles that. So we're more than happy to help as much as we can. So, Amy, back to you.
Okay. I don't know how you all felt, but after I hear Joe talking, I'm very grateful I have somebody like that to go to, and I need answers to my eligibility questions. So when we were preparing this talk, we realized that in order to access any services that the VA may offer and be appropriate, you need to then be eligible and enrolled in the VA. Joe's had a couple people come in this week where they need services, and the Korean War veteran has never been enrolled in services. And you also need to have a VA medical home. This is my only slide on this. So, yes, you can be enrolled like at the Portland VA and not have a primary care provider and request services, but it is not smooth. It's not easy at best, but it's very important that you have a primary care doctor assigned to you. Now, it's going to be a little bit different at every VA. There's certain federal guidelines. Every place works a little bit different with respect to services and their stance on different regulations, but by and large, you need the primary care provider. So I put in some acronyms here that you're going to need if you may call PCP, primary care provider. PACT, patient-aligned care teams. That's the medical team that provides your care in the CBOC, the community-based outpatient clinic. And that's usually the provider, the nurse case manager, the social worker, etc. And then again, the CBOC. So those are the words that you're going to need. You can just take this slide with you so when people throw it around, you can follow along and get the information that you need. Okay, so now I'm going to go into the VHAs, the VA long-term care services that are available on a national level. Again, it may be different at your particular nearest VA depending on rural or urban where you are. Not all programs can go everywhere, especially into the most rural areas, which I realize is a problem. I lived this problem when I was up in Tuba City. We'd have to send our very elderly Navajo-speaking only patients 250 miles away to Phoenix because we didn't have a nursing facility. So within the confines of what's possible to do, I'll give you this basic outline so that you've just got it for reference. So within the long-term care services, usually it's under Home and Community-Based Services Department at the VA. And then we have the programs that are provided through purchase care. We can buy it in the community, and I'll speak a little bit to all these different programs. And then we have home-based primary care, which is a VA-sponsored primary care program. And I'll speak about all of these. So I don't know if the acronyms matter so much, the MDCC and then CHOICE, but probably most people have heard about CHOICE. At least it's a very hot topic, a very rapidly moving program within the VA. CHOICE was there are just two different pots of money, non-VA care in the community and CHOICE. And CHOICE is a new pot of money that was given to us by Congress to help purchase care in the community when the VA cannot provide it in a timely manner. So it may help, certainly in some of your rural areas where the VA may not have the program that you need that we're going to talk about, but we would be able to purchase it in the community. So the things that are eligible for CHOICE are some of the programs that we're going to talk about, and you'll just save this for reference. So respite, hospice, sometimes home infusion that might be a little bit harder in a rural community, and this is ever changing with time. A year ago, only one of these programs was eligible. Now more are eligible. So again, the MDCC and the choice are just two different pots of money that the VA can access in order to provide care in the community. Now I'm going to go into the details of each program just briefly. The home-based primary care, that's where I do my clinical work. I provide care to actually patients who have ALS, which is amyotrophic lateral sclerosis, Lou Gehrig's disease, where they get progressively paralyzed and they can end up on ventilators and tube feeding, and some of those patients are at home. I go to the home to provide that care. So it's a unique program to the VA. There's nothing really like it in private sector, although they're starting to develop models now because it's shown to really reduce hospitalizations and length of stay. And it's an interdisciplinary group, so we have nurses, nurse practitioners, social workers, nurses, LPNs, psychologists, pharmacists, dietitians that all travel out to the home to provide primary care to veterans who can't get into clinic or when clinic care is not effective for whatever reason. And I'm going to keep this all at a national level because you don't really care about the nuances of what we have at Portland, but it would be useful for you to hear the rest. And the goal of HBPC is to keep patients in their home as long as it's safe, to provide enough support for the caregiver and the home and bring in all the medical and social support that they don't have to go to a nursing facility or a foster home. So HBPC began as a national pilot in 1970, and now when I updated these slides, in 2014 we had 23,000 veterans enrolled in this program nationwide, and we currently have 37,000 enrolled. I expect that most places it's always a little harder to provide this program services in the more rural areas because it involves driving, and it just becomes difficult for the funding and the staffing necessary to cover sparse population areas. And again, every HBPC program is unique depending on the individual facility, the budget, the needs, and what the veterans need and the communities need in the area. So we divide our purchase care into skilled home health and unskilled home health. That's just a way I have to organize it. And for skilled home health, that's this is what we purchase in the community. These are the agencies, the home health agencies that you guys all work with. So the skilled needs, all veterans are eligible for care, but they have to have a skilled need. They have to need a nurse, a physical therapist, occupational therapist, speech therapist, or social worker. Needing somebody to help cook your meals for personal caregiving, those are not skilled. Those are unskilled, and we'll talk about those later. And they should be homebound. The agencies that give these services that we purchase from the agencies, they get their funding many times from Medicare, although the VA does pay for some of them. So they're bound by these regulations. It's homebound, there's definitions, and each agency interprets it a little bit differently. But usually it's where somebody requires either it's impossible to get out of the home or it requires extraordinary effort in order to do so. And then they have a provider that follows the episode of care, usually in the VA. This is why you need your VA provider. And then they have to have a face-to-face visit with the provider within 30 days. And for these, the community skilled home health, usually it's short-term focused care. So it's like a wound that gets better. It's physical therapy. The guy gets stronger after a stroke. He doesn't need to stay in the program. It's focused. HBPC, on the other hand, keeps people in for the long haul, and our patients are usually very, very sick and complicated and are expected to decline with time. So there's two other skilled services, hospice, which is end-of-life care. And for the agencies themselves, I believe the Medicare criteria is it's reasonable to think that they may die within 6 months. And usually the provider can give documentation to that. And then you're probably familiar with all the wonderful things that hospice can provide so that the veterans get the care they need as they get sicker. PACOS enrollment is another whole hour discussion, and I probably should just take that out. PACOS is a federal registration that the physician needs to maintain in order to write home health orders. And then home infusion, I don't know how many VAs have this. At the Portland VA, we have it where people can go home on home IV antibiotics, and we purchase one of the home health agencies to provide oversight of their long-term IV line or antibiotics. Keeps them out of the hospital, and people really love this when it's necessary. Now we're going to move to the purchase care non-skilled side. We just talked about the skilled, those 3 programs, and now the non-skilled services. So for all of these services, and this is at a federal level, so you'll have this for reference, but the eligibility requirements, to be eligible to receive non-skilled services, you need to have a deficiency in 3 or more ADLs, activity of daily living. So that's the basic things that you need in order to take care of yourself at home. Bathing, dressing, eating, toileting, meal preparation. Those are the 5 big ones. So if you're deficient in 3 or more of those, or you have a significant cognitive impairment, so dementia, or you're thinking of services that you need because you're on hospice, then you would likely be eligible for some of these programs. So if you need help with 3 or more, and that's felt to be the basic nursing home level of care. So if you just have one of them, it doesn't count. Or you can have the second one is, so maybe you only have you have a deficit in 2 activity of daily living. You can't feed yourself, and you need help with your bathing. Then if you have one of those other things, 75 years, you're living alone, you're depressed, the things that put you at higher risk, that would be considered a qualification also. And so if you fall into those categories where you need additional help in order to stay at home, the VA can purchase different things for you. One I'm very involved with here is contract nursing homes. So eligibility for this program, these are people who can't stay at home anymore and need to go into a facility, into a nursing facility. So they have a deficit in 3 or more of their activity of daily living, but if they're mill bill, which I assume, Joe, is military bill. We just always say mill bill.
I do remember hearing what that meant once before.
Okay. Don't remember now.
Don't remember what that meant.
So if they're 70% service-connected or greater, they're going to qualify for placement in those categories. Short-term placement, which is skilled, a nursing facility, long-term placement, or respite. Or end of life. So at the VA, so Medicare is 6 months or less. The VA is 1 to 2 months of life expectation, and they have to be nursing home level of care for all placements. The beauty of this program is that the VA, so we have 40 contracted nursing facilities within the VA Portland healthcare system. And we have about 106 veterans in this program now, and we've got a staff that goes out and follows and monitors their placements, how they're doing, if there's any problems with the nursing facility, if they give appropriate and good level of care. I think it's a very valuable program to have. And then there's something called the state veterans homes. We have 2 in Oregon at the Dalles and a brand new one in Lebanon. And they're actually run by the State Department of Veterans Affairs. And we have a collaborative relationship with them. So we provide annual inspections. We have a lot of our veterans in those homes. And it's a collaboration between the VA, the State Veterans Home, and the community. So not a federal program, but we do have a relationship under long-term care services with them. 2 other programs, Homemaker Home Health Aide. That's a much-loved program in the VA, and there's a lot of need. So these are the unskilled people, the caregivers, who go in and help with ADLs, the bathing, dressing, eating, toileting, and meal prep. They use a standardized assessment to determine how many hours per week, but it's different everywhere. So at the Portland VA, we provide these services about 18 hours a week of paid caregiving to go into the home to help veterans who qualify. But we can't take care of everybody. We only have about 290 on the list now. But at other VAs, even in the same locality, they may take 700 patients but give them 3 hours a week. So there's different ways that people choose to distribute the fund of money that they have. But here we prioritize patients at the end of life, or if they're discharging from inpatient from our community living center or CNA contract nursing home, because the periods of transition are very a difficult time, and it's a high-risk time when patients' clinical condition can deteriorate. And then we have outpatient respite. Respite is when we give relief to the caregivers. If there's anything I've learned in home-based primary care, it's a true respect and for the caregiving that people are giving to their veterans in need. It's very energy intensive, and we can either bring them sometimes to the community living center, or we can purchase it here in the community. So we'll send them to a contract nursing home for a week or two while the caregiver gets a break and either does something special or takes care of themselves. 2 other programs are community adult day health care. We don't have a very big program here at the Portland VA. Other places are bigger. And these are just we contract with programs in the community so that primarily people with dementia or significant ADL needs, again, they have to have ADL deficits, activity of daily living, can go for daycare, relieving the caregiver of some of the stress of 24/7 care. And then there's a new program, veteran-directed home and community-based service, veteran-directed. That's a new program, relatively new, and it's a collaborative effort with the counties and with the Department of Aging Services, and we have collaboratives with 2 counties in the Portland metro area, and we probably have about 30 people. So we'll pay some money to the county and aging services, and then they manage the funding that goes to those veterans. And the last thing I wanted to talk about was the Community Living Center. This is a picture of the Portland CLC, and it's a national system of nursing facilities. I think there's about 130 nationwide, and there's many different level of bed options. We're always talking about the best way, how much should we provide here, how much should we purchase in the community, what's the optimal way to make our funds count to provide the best services for our veterans. So here we have skilled nursing, which is IV, antibiotics, wound care, physical and occupational therapy. We have acute rehabilitation, where people are like post-stroke or gait training, where people can have up to 2 or 3 hours of rehab a day. We have respite care. People will bring in their veterans for a week, maybe once or twice a year, but it allows them a little bit of time off to refresh. We do have hospice beds. We do palliative care, which is what we call, we have about 5 or 6 patients at any one time who are getting complicated chemotherapy regimens and require visits back and forth to the Portland VA, and it just wouldn't be possible from where they live. And then we have some long-term care beds. The veterans have been accepted into this bed placement, and they'll stay for the remainder of their time. And that's a picture of the Portland VA, and I think at this time our presentation is over and we can open for questions.
That's right. Thank you, Amy. So this is our question and answer period. We have about 15 minutes left for it, and we have a lot of questions that have come in through the Q&A box. So thanks, everyone, for sending those in and for your participation. Because the focus of our webinar series is long-term services and supports, I'm going to start with the questions that are related to long-term care services. There are plenty of eligibility questions, and if we have time, we'll get to those. And I'm also going to ask Joe to give some thought to some closing words for us where you describe what should people's first step be. For all of these eligibility questions, what should folks do first? So I'll call on you for that in just a moment. Also, as we're moving into Q&A time, I want to remind our audience members that you're able to download today's slides in the box that's at the middle right hand on your screen. Click the file name, click the button that says Download Files, and that'll give you a copy of today's slides. And I know particularly in the eligibility section, there was some information there that people have been interested in. So download the slides, and we will move forward with the questions that have come in. One thing that I'm seeing from a couple folks in the question box is, what is the difference between hospice care through VA and hospice care through Medicare?
When I was talking about hospice care through the VA, I was referring to hospice care that we purchase. So purchase care through the VA. So it will be the same agencies providing the care, but the difference is that we reevaluate every month or two to see if they still qualify, because sometimes in the community people go on hospice and then they're in for a year or two, and we would probably not continue paying unless somebody was truly felt to be end of life.
That's related to another comment that someone had, that they're aware of cases where people can be on hospice for a number of years under Medicare, but it sounds like that would be a different situation if it was encountered in VA care.
That's correct. It's the same agencies providing the care, but we're more stringent in our application of how many months somebody can stay on.
Great. Thanks for clarifying that. So another couple questions. Again, I'm grouping together a couple questions that are related. Folks are wondering about, are spouses eligible for long-term care services? Are there any of these services that you've talked about that are available to family members of veterans?
No, unfortunately not. It's only to the veteran. We have some very limited ability to do post-death bereavement services and follow-up, but not directly for the spouses.
Sarah, if I could interject just for a second. This actually was a question I received from a veteran this morning right before we started this. And as a whole, family member services from the VA are extremely limited. Predominantly, it is things of nature. If the veteran's a post-9/11 veteran and they are substantially disabled and their family member is a certified caregiver, mental health provides some stress management care for those family members. If a veteran's 100% permanent and total disabled, then through CHAMP VA, which is a separate health eligibility insurance, more or less, there are some benefits, but those are really the exception, not the rule.
And just he brought up something. So we do have some caregiver support services. In order to, I think of it as to make sure the veteran gets what they need. So if we do a better job with taking care of our caregivers emotionally, and it would be mental health and emotional support. It wouldn't be medical. So we have caregiver support services here, but it's to allow them to take better care of the veterans.
Okay, thanks for that additional information. Now there are some kind of more administrative questions related to long-term care. One person asks, are there specific LTSS agreements that VA has with specific tribes?
Oh, let me think about this. Can you repeat the question, Sarah? Are there specific long-term care services contracts?
Are there specific agreements for long-term care, contracts or any other type of agreement that are made with specific tribes? The
only thing that comes to mind is something that you yourself, Sarah, have worked with I call it the Native American Initiative, which is at 12 sites across the United States. And we have 2 here at the Portland VA, which is in Warm Springs and Bend in the Grand Bronx tribe, where we're trying to improve access to VA care for the natives living on the reservation. We try to get HBTC services in there. We're trying to increase the ability of I think Warm Springs is IHS and Grand Ronde is compacted, but trying to allow their providers to get more services from the VA. But I can't think of, I don't know if there's anything more formal than that.
Okay.
And one of your speakers coming up is going to be talking about that, right?
That's correct. I was
Dr. Kramer.
Yep. Well, Dr. Kramer is going to talk about her program, which is a partnership program with Indian health facilities related to primary care. She'll be giving a brief presentation on that on March 22nd. Prior to that, on February 22nd, we have a presenter who works collaboratively. She's an employee of the VA. She works collaboratively with tribes in Arizona on connecting them with VA services and just increasing their collaboration. So she'll be presenting that on February 22nd, and it sounds like it is an example of the program you were just describing.
Okay.
So those, for our audience members, those are webinars that we're having with more VA information to keep in mind for the future. Another question that we have is, again, from the provider standpoint, is it difficult to open or start purchased clinics? I have a passion for long-term care and veterans, the audience member says. I'm interested in opening one in my community. How hard would that be? What would the process be like?
So this provider is not a VA employee, but interested in opening or having some of these programs available in her local community?
Yeah, interested in opening a program and working in it and serving veterans, but no, they're not presently a VA employee.
Ooh. You know what? I'd love to talk more about that because new programs are always fun to think about how we could implement, but it might be better if she just called me directly.
Okay, so for the person
Go
ahead, Amy.
My contact information is there. I'd be happy to talk to her about ideas and the specifics of what she has in mind, because the only thing I can think of is that she would have to work through a home health agency that is contracted or paid for from the VA. So it would depend on the need and the demographics of the area and how many veterans needed to be in that program and if there was an interested home health agency and a lot of things. It would be an interesting discussion, though.
Yeah, so for the person who had that question and for anyone else who has questions like that, I want to point you back to Dr. Amy Light's email address, which is on the screen right now, and it'll be available in the slides if you download them. And Dr. Light, it's really gracious that you're making yourself available to kind of discuss some of these specifics with folks for the very detailed questions that they have.
Right.
Now, this is somewhat related question, and it may just be the same answer of let's discuss it in more detail offline. But the question is, an audience member says, I own and operate an assisted living home in Ketchikan, Alaska. I'm looking to expand and would like to include vets. Who should this person talk to about possible funding or other elements of that, expanding to include vets?
Actually, that would be, I'd love to speak to that person. And I could even, if they contact me, get me, information about where they are, I'll find out who they would talk to. Because what they're probably asking for is how to initiate a contract with the home and community-based program that operates the contract nursing homes.
Okay, great. Well,
I'm sure it's doable, but it would be easier if I had more information. I'll call up to the VA and get a name.
I'll make sure that I give you her information, and you two can discuss that at more detail offline. So thanks for making yourself available for that detailed stuff.
I'm happy to do it. It's very difficult to know who to call in the VA.
Mm-hmm.
Joe and I agree with that.
Here's another question. The question is, how are veterans in rural areas determined eligible to receive the HAHA services that you mentioned, those different types of health aides?
Right. It's the same as in it. They would have to qualify by respective their activity of daily living deficit. So getting back to, let's see. Do you see that? Let's go back to that slide about eligibility requirements for non-skilled. Can you see this slide now, the non-skilled services?
Yes.
So HAHA is a non-skilled service. It's a non-skilled service. So the veteran would need to be enrolled. It would be 100% preferable if they do have a VA primary care physician, and then they need to be eligible. So it's 3 or more ADL. So they're not able to take care of themselves. They need assistance to take care of their basic needs. And then it depends on your VA, because everybody divvies up all these programs, how much money they have, the need, they divide it up differently. So you would go to your primary care doc. You're packed, the primary care team, patient-aligned care team is the leader of your ship at the VA. And you would go to your social worker probably in the PAC team and the doctor and say, I think that we need some help at home, and we've heard about HAHA. What options are available where we live? And then they would look and see if they're able to assist in that, depending on that particular VA. But go back, your questions for these services is to go back to your primary care team, because they're the ones that put in the consults and the referrals that can help guide you through the system.
Okay, thanks.
That was a good question. Did that answer appropriately in enough detail?
I think that's good for now, and if the person who asked it has additional follow-up questions, go ahead and enter those in the Q&A box. So we're coming close to the end of our hour, and there are definitely more questions that folks have entered than we'll have time to cover today. So we're going to look at a way to follow up on those questions afterwards. All of you audience members who've joined us today, we have your email address because you registered for the webinar. And so if we have additional information, particularly specific follow-up to the questions that you've asked, we'll be sending it to you via email. So we'll see what we can provide in that area. I want to turn back to one comment in the Q&A box. An audience member says, the Office of Tribal Government Relations may be able to help tribes open programs. And I think that acknowledgement of VA's Office of Tribal Government Relations is really important. If you Google VA Tribal, it's easy to find on the internet, and they are really VA's way of reaching out and consulting with tribal governments and finding out about the needs specific to tribal veterans and tribal communities. So that is another excellent place to start when you're looking at VA and you're not sure where to begin, and that's VA's Office of Tribal Government Relations. So now, with just a couple minutes left, I want to ask both of our presenters for their closing thoughts. And I want to go to Joe first and say, for all of the eligibility issues that we've covered today, what is your recommendation for where folks should start when they have questions?
Well, the real simple answer to that, Sarah, is get on the internet and go to www.va.gov/health-benefits. And health benefits is all one word, and you're going to find more links to information and access than you'll possibly need. You can apply online. There's a phone number on there. It's a toll-free number that will connect you with an expert that can help you analyze your eligibility. That number is 877-222-VETS.
Okay, great. So
there's links to all the information you need right there.
All right. So va.gov/health benefits, and the phone number is 877-222-VETS, VETS, and that's a place to start on eligibility. Any other concluding thoughts you want to share today, Joe?
Well, the one thing that I always tell veterans is the only day better than today to apply is yesterday. So don't waste time. We can do more for you now than we can when it starts to get to be too late. And when your family member or neighbor or cousin or whoever it is needing these long-term care services, you've waited too long. So don't do that. Get in today, get enrolled, take care of the eligibility. Even if you don't use the services right now, you're in the system. It's a lot easier to get the ball rolling down the road later on than it is to try to scramble at the last minute in the 11th hour and put somebody in the system when it's, becoming critical.
Great. Thank you for those words. Dr. Light, do you have any concluding thoughts you want to share with us?
I can't think of anything beyond what I've stated, except that I really enjoyed giving this presentation. I always learn a lot when I prepare, and thank you for inviting both of us to hopefully share a little bit of insight into what the VA has and how to access care.
Absolutely, and we are really grateful that you were able to join us and to share your expertise. The level of interest in this topic is very, very high, and we've kind of only scratched the surface of it. So thank you so much for what you were able to offer to us today, and thank you for presenting. For our audience members, I want to remind you several things. Remember, you can download the slides today in the box at the middle of the right-hand column on your screen. We also recorded today's webinar, and it's going to be posted on cms.gov in the near future. We get those up in about 7 to 10 days. Some other folks asked about information about the upcoming February 22nd and March 22nd webinar presentations that are also about other areas of VA and veterans care. If you received an email about today's webinar, you are on our email list, and you'll receive a webinar you'll receive an email about those upcoming webinars with the ability to register as well. We'll be sending those out and getting them to you via our email list. And that is all that we have time for today. Thank you for joining, and thanks to our presenters for talking with us. The information will be made available later online, and for today, that concludes our session. Thanks, everyone, for joining. You may disconnect now.